Physiology of the heart. Cardiac output is equal to stroke volume multiplied by heart rate. These three factors are going to affect your stroke volume. You have cardiac contractility, inotropic, afterload, and preload. Any condition that impairs preload, afterload, cardiac contractility, or heart rate can cause heart failure. Wow, this is easy. According to Starling's law of the heart, Starling's law, that's important, increased venous return augments preload. Heart muscle fibers stretch in response to expanded volume, preload, before contracting. The stretching allows the heart to eject more forcefully in the additional volume, thereby boosting stroke volume. So think like a rubber band. The more you stretch it, the more potential energy shoots back. In normal heart, the greater the preload, the greater the force of ventricular contraction, the greater the stroke volume, resulting in increased cardiac output. Two types of left ventricular failure. So we have systolic failure. The left ventricle doesn't contract normally and has trouble pumping out all of the blood to the body. Diastolic failure. This is whenever the left ventricle contracts normally, but it becomes stiff, impeding its ability to relax and fill with blood between each contraction of the heart. Common causes could be faulty heart valves, AMI, acute myocardial infarction, cardiomyopathy, and excessive volume or pressure. Left ventricular failure. So blood is going to back up behind it, causing a chain reaction. The right side continues to pump normally. The left side cannot keep up and pressure increases. Pressure within the pulmonary vessels increase. Fluid is forced out of the pulmonary capillaries into the alveoli, which would then create pulmonary edema. Buildup of fluid widens the gap between the alveoli and capillary membrane. This impairs diffusion of oxygen and carbon dioxide. I was about to say monoxide. So if we look at this whole circle here, high pressure in pulmonary capillary leads to pulmonary congestion, which is going to lead to impaired gas exchange, signs of hypoxia, possible cyanosis, pulmonary edema, orthopnea, cough, frothy sputum, paroxysmal nocturnal dyspnea. Okay, so let's see, what are these words? Pulmonary edema, there's fluid in the lungs. Orthopnea, so whenever you're not in a certain position, most likely laying down, you can't breathe. You have to sit up to breathe. Cough with frothy sputum, so you're going to see foam, possibly bloody pink. Paroxysmal nocturnal dyspnea, so nocturnal, nighttime dyspnea, not breathing. Paroxysmal, that one's got me. I want to say like paradoxical, but it's not paradoxical, it's paroxysmal. So basically, not being able to sleep at night, plus whatever that means. Left ventricle weakens and cannot empty. That's going to lead to decreased cardiac output, which is going to lead to our activity intolerance and signs of decreased tissue perfusion. We're going to see more cyanoticness happening. Decreased perfusion to the kidneys, we don't want that, but that's going to lead to renin, angiotensin, aldosterone system activated. So the body is about to compensate. Sodium and water retention is happening, and backup of blood into the pulmonary veins. There's our circle of heart failure. Left ventricular heart failure. Right ventricular failure. So this is to eject blood within its walls to the right ventricle must overcome high pressure and congestion within the pulmonary vessels. So our pathophysiology for that. Starting at the top with the kidneys, renin, angiotensin, aldosterone system is activated, which then makes sodium and water retention, backup of blood into the systemic circulation, also known as the vena cava, your large vein right below the heart. Increased venous pressure results in edema in legs, liver, and abdominal organs. There's fluid that is being just pulling pretty much in your legs, your extremities, You might get clubbing, I believe, is a sign. High venous pressure causes neck veins and distension and cerebral edema. Again, it's backing up into the system. So these are your arteries, and it's not arteries, JVD, jugular vein distension. Right ventricle weakens and cannot empty. Decreased cardiac output, decreased perfusion to the kidneys, circles back to our renin-angiotensin-aldosterone system. When it cannot keep up with increased workload, the right ventricle fails. Blood backs up behind the right ventricle, raising pressure in the right atrium. Blood backs up into the superior and inferior vena cava. The veins become congested with blood, organs become congested with blood. Rising pressure within the veins forces serous fluid through the capillary walls and into the body's tissue, producing edema. So it's not blood that's causing that swelling, it is serous fluid. Peripheral edema is apparent in the feet and the ankles. Serous fluid may also build up in the abdomen. This is going to be ascites. Ascites comes from the Greek word for to pour out of, but because it's it means the opposite of to pour out of. Ascites, not pouring, means it's full of fluid in the liver, ascites. Pleural cavity, pleural effusion. Pericardial activity, pericardial effusion. As right ventricular failure progresses, generalized edema of the entire body can occur. This is anisacaria. Cor pulmonale, right ventricular failure may occur by itself without left ventricular failure. In conditions such as right ventricular, what is that I? I forget what the I means. RVI. Right ventricular something. Pulmonary embolism, pulmonary hypertension. Pulmonary embolism is, we talked about that briefly with how you can read that on a 12 lead. So it is a block, could dislodge from a clot in your leg, come up to the lung and prevent blood perfusion, blood flow in your pulmonary arteries or veins. Pulmonary hypertension is a disorder, most likely your vein. Pulmonary hypertension is a disorder in which the pressure in the pulmonary arteries is higher than normal. Right ventricle must work hard to overcome increased resistance to eject blood. The right ventricle enlarges and will eventually fail. Right ventricular failure caused by pulmonary disease is called cor pulmonale, usually the result of COPD. Compensatory mechanisms. So compensatory mechanisms that attempt to improve cardiac output by manipulating the following. We have preload, we have afterload, we have heart rate, cardiac contractility, and ultimately compensatory mechanisms may worsen heart failure. The sympathetic nervous system, this is something that's affected by that. So it's going to boost the heart rate. It's going to increase the force of contraction and constrict blood vessels. Some of the names for these, so for boosting the heart rate, rates going up, chronotrophy. I never know if it's chronotrophy or dromotrophy. I forget the difference between the two. Increased force contraction, enotrophy, and constricts the blood vessels, alpha receptors do that, I believe. I don't know. We'll have to look into it. The accelerated heart rate and stronger force of contraction. So we have increase of the heart's oxygen demand, reduces the amount of the time that the ventricles have to fill. Decrease the time for the coronary artery perfusion. Stimulation of the renin-angiotensin-aldosterone system by decreased blood flow to the kidneys. The heart has to work even harder to pump against high pressure. Aldosterone encourages sodium and water retention and increased blood volume to increased preload. Compensatory mechanisms. Increased cardiac output for a time, but eventually the heart failure advances. Sodium and water retention enlarges the heart chambers. Ventricle wall thickens, weakening the force of contraction. The force of contraction decreases. The heart is unable to handle the increased fluid volume and cardiac output decreases. We're decompensating now. Assessment. So we're doing an assessment, the patient report. We want to, what we're finding is a sudden Onset, shortness of breath. A shortness of breath that is worsened through a period of hours or days persists at even rests. The likelihood of cardiac origin is greater if the patient has a history of heart attack, high blood pressure, valvular disease, none of these. Cardiovascular conditions, and then the patient may report having trouble sleeping. The patient can often report feeling tired, weak. The patient may report having trouble concentrating. May be the result of hypoxia. Other symptoms include nausea, the loss of appetite, feeling of faintness, palpitations, irregular, rapid pulses, feelings of faintness. Ask the patient about prescribed medication, specifically beta blockers, calcium channel blockers. How can we counteract calcium channel blockers? It's not atropine. What is it? I'm already forgetting all the stuff that I've been going over. So restlessness, anxiety, unexplained confusion may be a result of hypoxia. The sympathetic nervous system response to hypoxia and the body's compensatory mechanism maintain cardiac output because of these systems. The rapid respiratory rate and heart rate. We have pale, cool skin, diminished peripheral pulses, increased work of breathing. As hypoxia worsens, the patient may become cyanotic or could cough frequently. What am I blinking for? I guess it thinks I'm moving. If RVF accompanies LVF, left ventricular failure, then jugular venous distension will be visible as the venous system becomes congested. Patients who are able to walk will have swelling of the ankles, feet, calves, or legs. If edema is present, and note and document if it is pitting, non-pitting, localized in the ankles to mid-calf or to the knees. Ascites may also occur. As the pump continues to fail, the heart rate begins to slow, blood pressure falls, cardiac output decreases substantially. Cardiogenic shock occurs whenever heart failure is accompanied by hypotension. Look at these. So signs and symptoms present within the heart that could be heart failure may be present with other conditions, such as cardiovascular causes. We have cardiac tamponade, cardiogenic pulmonary edema, cardiogenic shock, high altitude pulmonary edema, myocardial ischemia, myocardial infarction, non-cardiogenic pulmonary edema, and pulmonary embolism. I'm just going to go through, I'm going to describe these as much as I can. So respiratory causes, we have acute respiratory distress syndrome. So direct onset out of nowhere. Asthma, we know what asthma is. Chronic bronchitis, you have been producing fluid, that phlegmy crap in your lungs constantly. Then there is chronic obstructive pulmonary disease, COPD. We treat that with CPAP because we want to blow all of that the obstruction out of the way. So that way it would also decrease the heart rate and the heart pressure. A lot of things get taken care of with COPD. It's like a multi-step, like put this in order so that gets in order so that gets in order, and will compensate the person well. Pneumonia, fluid in the lungs, pneumothorax. If you have not tension pneumothorax. Not being able to, so pneumo is air, thorax is in the middle. Tension pneumothorax is if you have very tight in your chest, like a drum, and you're listening. Pneumothorax, maybe a rupture. I gotta look into that again. Respiratory failure, just completely not being able to breathe at all. You are fully decompensated, we are BBMing you. Anaphylaxis, aspirations, toxin exposure. Toxin could be anything. Aspiration is any kind of foreign airway or fluid getting into your lung that's not supposed to be there. Anaphylaxis will happen before anaphylactic shock, and an allergic reaction can also, I believe it happens with asthma as well. So management, we have goals: decrease the respiratory distress, the work of breathing, maintain adequate oxygenation and perfusion, direct supportive efforts towards decreasing the workload of the heart. We're going to offer patient reassurance, make sure that they stay calm. Place him or her in a position of comfort. We're going to place him or her in a sitting position. Oh, you know what? This is where it started at? No, it started here. That's all.